and I am joined by my co-host Egwu. Now, tonight we come to you not as diversity leaders at Google and Bank of America, respectively, but instead as two Black men who care about the state of the Black community and thus want to put voice to and provide information on important, relevant topics so that we can continue to progress as a society. If that resonates with you, we ask that you please subscribe to our YouTube channel so that you can stay connected with us. Also, if you want to check out episode 1, which was on navigating today's job market, you can find the video on our channel. All right. So as you have seen by now in all the comms around this, Egwu and I are joined by 3 incredible medical leaders who are on the front lines in one shape or form, helping us get through these crazy times. I want to first introduce Dr. Brandy Jewett-Patrickson. Dr. Jewett-Patrickson earned her medical degree from Morehouse School of Medicine. She is an inpatient physician and is based just outside of Atlanta. Welcome. Next up, I want to introduce Dr. Akuna Ihanacho. Dr. Ihanacho earned her PhD in cellular and molecular physiology from Johns Hopkins University, and she is based in Maryland. Last but not least, I want to introduce Dr. Baroni Richardson. Dr. Richardson earned his medical degree from New York College. He is both a medical director with Anthem Health and a primary care physician, and he is based in Los Angeles. Welcome to our guests. And, before we jump into tonight's episode, Egwu, we would be remiss not to speak on the sheer fact that our community and frankly, our country is dealing with more than just a pandemic. I'm not ready to talk about the pandemic yet, honestly. These times are crazy. We've been having these conversations. What do you think?
Yeah, it's been a tough week. Anyone you speak to, it's been an emotional roller coaster. Constantly being reminded of things that we thought or we wish to be in our past, but keep on coming up. I think one of the names this week that is to be remembered, or a name that has great significance, is the name Cooper. And I know a lot of people immediately go to Amy Cooper, who was the woman who falsely accused or called the police on Christian Cooper in the park. But I actually delved into Mr. Martin Cooper, who in the 70s worked for Motorola and was credited as finding and being the inventor of the cell phone. So years ago when he was inventing a mobile device, I don't think he realized that would become what would become the evidence of social injustices that have gone. In the last few weeks, how many of us would have seen what we saw with the cell phone cameras that everyone's been taking? So as we try to move forward, maybe the cell phone will become the new TV camera, what the TV camera was to the civil rights movement. I think the cell phone will become that awakening for all of us in the United States and in the world to see the injustices that are going on.
That's rich, honestly. We've obviously seen situations when the camera is on and the video footage doesn't change the outcome, doesn't lead to justice. But I think we need to see, even it's so tough to see, but we need to see the footage in order for us to continue the fight. So thank you for sharing that. I actually didn't know much about the history there of Martin Cooper. So thanks for sharing that. All right. So, let's move into tonight's discussion. On top of all that's going on within the Black community, within this country, we have this novel disease that is absolutely wreaking havoc on the world. There's a lot of knowns, there's a lot of unknowns and misinformation out there. So, turning to you, Dr. Jewett-Patrickson, first, as someone who's on the front lines in these hospitals, what are you seeing as kind of the biggest differences between today and then pre-COVID?
The main thing we're seeing is a lot of fear. There's a lot of patients who are very fearful to come into the hospital. They believe they will be exposed if they come for any other reason. They have canceled any elective procedures. They don't want to even visit their doctor's office. They don't want to bring their family members in because they think if I drop my family member off, I'm never going to see them again. And there's fear on the staff side as well. You know, we treat probably 60 to 70 COVID patients daily in my hospital. And they're afraid that running out of PPEs, we don't have the protective equipment, that they're going to expose themselves and then later take that back home. So people are not comfortable anymore coming in, and it's the whole entire nation. And so we're seeing a difference in our numbers in the hospital. They have significantly decreased.
Interesting. So, you're based just outside of Atlanta. Atlanta and Georgia in general have been in the news about opening up maybe prematurely, who knows. But where you are outside of Atlanta, before COVID versus now, what is the makeup of your patient load? So can you give that insight into like who you're seeing now versus who you used to see on the regular?
Right. Yes. So I do work in Fayetteville, Georgia, and I work in Noonan, Georgia. And these are higher Caucasian, more elderly patients. They range anywhere from 60s to even in their hundreds. And I would say we would service about 70% Caucasian and 30% minority, 30 to 40%. But it's changed. Since COVID, we have seen more minorities come into the hospital because of the severity of their illness. And so it's changed. It's actually swapped to where it's now 60% minority, more African Americans, and maybe about 30, 40% Caucasian.
So one of the things so with that change, and this is mainly for Akuna, I want to ask a question because she's more on the side of, not only the cure side or the vaccinational side. But I want to ask a question about historically speaking. I think if we look back to what African Americans and Black people in general around the globe have found themselves at odds with the medical system at some point in our history, right? And that's created these waves of distrust and stuff with vaccinations and some of the recommendations of physicians. So can you give us a little bit on how that history came and how we got to the point here where some people are less receptive to the advice that comes?
So there are several different things at play. So one thing that we can consider or think about is just the long history of experimental abuse, when experiments were conducted without informed consent. And some cases that are probably more familiar than others, Henrietta Lacks is a case that is often cited, as well as the syphilis study that was also conducted. So these abuses have contributed to now this legacy of mistrust that is often inherent within our community. But even as you say that too, if you look at the conditions in which we live, we work, and we play, all of these things also factor or contribute into our health. And so during public health emergency,
well?
Sure.
I also want to say that even now, I've seen many patients who believe that their family members are being mistreated even today in 2020. They believe OB-GYN, if they come in to have a baby, they won't get the same care as their Caucasian counterpart. And so I always want to express to African Americans that you have to find a physician you trust. And you have to make sure that, you agree with their care, and that you believe they're taking good care of you. And it's okay to shop around and get the doctor, the physician that you feel the most comfortable with. There's nothing wrong with that.
I would say too, there is some modern history with that too, right? Where, especially if you're talking about OBGYN and women and having babies, there's a lot that we read about African Americans having less favorable results for the same type of medical procedures that other people have. So when it comes back to COVID-19, and this is a question both of you can kind of answer as far as a treatment, is there different treatments that are appropriate for African Americans rather than other people? Or is there success that's found doing X and not Y, and it's specific by race?
Well, I think even if we were to back up and talk a little bit about not only what is happening during public health emergencies, but also considering how some of the existing conditions kind of can isolate us from the resources that are needed to respond to an outbreak. So for many people that are racial and ethnic minorities, they live in conditions that contribute to underlying health conditions. And these conditions make it challenging either to implement best practices for prevention or to seek treatment if they do in fact get sick. And there's several of them. Living conditions. If you are living in a densely populated area, due to institutional racism or because of residential housing segregation, it's going to be more difficult for you to practice prevention measures such as social distancing. And there's research that also suggests that where you physically live, it's been linked to a variety of different adverse health outcomes and underlying health conditions, such as diabetes, such as hypertension, such as obesity. And these underlying conditions can also increase the likelihood of severe illness from COVID-19. Also, if you're immunocompromised, if you have HIV, you're going to be more likely or be more susceptible to COVID-19. And these are just a few.
On the front line.
I was going to say, and that's just talking about living conditions. There's also work circumstances can also contribute, as well as having less access to healthcare. All of those things will impact your outcome.
Yeah. And I'm agreeing with her, Dr. Ahanachu. I agree because we have less access to healthcare. And now with the COVID crisis, you have 38 million people who have lost their jobs. You have people who do not have health insurance anymore. This, is going to stop them from even wanting to see someone because you're going to be so afraid that I can't pay this bill. So you stay at home longer than you should. And this affects minorities heavily, staying at home, trying to cope with these illnesses and not coming to get seen. And that's a big issue that we're seeing is that the numbers are at this point about 1.7 million Americans have COVID-19 or have tested positive, and about just over 100,000 have died. And that's about 17%. And so what they're seeing is it's probably closer to more 20 to 23% because people are not coming in and they're actually passing away at their house. And so I'm always encouraging my patients to come in and we'll deal with the back end, with the money and things like that later, but you want to save your life. So that's the most important.
I just wanted to echo what Dr. Patrickson is saying. I work in a primary care clinic, urgent care clinic. So since COVID happened, we've switched to more of a telephone visit, video visit type of healthcare at this point. So those people are afraid to come in, they can just call in. So if you have any questions, find out how you can call in either through your insurance companies. They'll have avenues where they can hook you up with a telehealth doctor or a video health doctor, or call your primary care's office and see if they offer telephone appointments so that, you don't have to take that risk to come in, but you can still get your questions answered. And if you do need to come into the ER to be seen, then that's something we can direct you to do.
Dr. Richardson, on that line, what are some of the symptoms and the way that, someone's symptoms might present themselves that would allow you or push you into one of those two options?
So the most serious is difficulty breathing. So if you're having some shortness of breath that is out of the ordinary, you need to come in, either call, but you definitely need to be seen. I think if you called me and said I have difficulty breathing with other symptoms like fevers, body aches, or even just chest pain. Those are things that I would say, hey, you need to be seen in person to be evaluated, because the risk of you having something more serious than just a cold that we can give you a inhaler for or some antibiotics is a lot less likely in this situation.
So we've been talking about, some symptoms. We talked about some of the historics in terms of the trust in the medical system. Just curious, kind of taking a step back, one of the things that actually leads to some more trust is knowing that when you go to see a physician that you could possibly be cured. And so I guess my question is, this is really for Dr. Iheanacho, sorry. Where are we with a stable COVID-19 treatment approach? There's been a lot of information about what could be used, malaria pills one day, and then, we have our president saying another thing, of course. But where are we with kind of a stable treatment approach? And then even a step further, just given your experience in this field, a possible vaccination.
So presently, there are no treatments that have been shown either to prevent or to cure COVID-19. So there are several different randomized clinical trials that are in progress now, not only for antivirals, but also additionally for the development of a vaccine. So remdesivir was previously tested against or tried as an Ebola treatment. And it wasn't very effective as an Ebola treatment. But now, because it is an antiviral, it has generated very promising results in animal studies, as well as some initial trials with humans. And because it was effective against this family of viruses. So this particular COVID-19 comes from the family of coronaviruses. And so there is some data that suggests that it may have some effect in patients with COVID-19, which we have seen in some of the earlier clinical trials, and those are still ongoing. So none of those studies have been completed to date, but the results are looking promising on that end. There are also two other antivirals. They were actually developed as a licensed treatment for HIV, lopinavir and rotenavir. And they have been used in this particular, or at least in the clinical trials that I've seen, in concert. So they are both administered together, or as a booster. One is given and then the other follows as a booster. And the reason why the thinking was that they would try these is because they want to just see if they can identify and confirm if they have any benefit for COVID-19 patients. And yes, it's true that all of the medications that I have mentioned, they were developed for other viruses, but that's not necessarily uncommon in this particular field to repurpose other treatments. But there are limits to that. As you can see, there is some data that has come out regarding hydroquinone, and you can see that it's not effective. In fact, it has an adverse effect on COVID-19 patients. So they have since, or studies that included that, they have since now eliminated that particular research arm because it seems to be detrimental. And then regarding vaccine development, that's an ongoing thing. When you're developing a vaccine, you're trying to identify or target pieces of the virus that are necessary for it to function. And you want to, when you're developing a vaccine, you want something that's going to elicit an immune response, but not only an elicit an immune response, you want it to be protective. And then you want it also to be broadly neutralizing. So that work in terms of developing the vaccine before you even start testing it in humans, that can take years. Depending on which research lab or what company is working on it, some of them, they have pipelines and platforms that are already established. So for those companies, they might be able to reach an approved vaccine far quicker than, say, some of these other institutions that are just getting started. But once you develop it, you still have to test it in humans. And then there's, phase 1, phase 2, and phase 3 clinical trials before you get to the point where you have something that is approved and will be used. So that process can take a while, even when things are being fast-tracked.
So I know that your involvement previously, you've been involved with the Ebola vaccine, you've been involved with HIV vaccines. But the question I have for all of you, because some of you have lived through probably not a pandemic, but you've seen other things that move virally through other people. Have you ever seen anything like this that caused this much havoc? Maybe that might have had something that got under control pretty fast, or is this in terms of how lethal it is it much more than others?
It would seem to be. Another thing that's troubling about this particular virus is the long incubation time and the fact that you can be asymptomatic. So it's stealthy. So you could come in contact with several different people and you're asymptomatic and not even know that you have potentially passed the virus on to them. So I think that's what's most disconcerting about this virus. It's pretty sneaky, it's pretty stealthy, and you can have this long incubation time. And then there are some people who don't ever have symptoms. So they don't even know that they have come in contact with the virus and potentially passed it on to others. I think that's one of the things that makes this one so much worse than others.
So another thing, go ahead, Raina, please.
No, I was going to say, I'm agreeing with her. The definition of the pandemic is you have to have asymptomatic people to actually spread it, because if you knew who had it, then it would be easy to contain. And so we've never in the hospital seen anything like this, where people will literally come in. I spoke to several pulmonologists today, and it's so scary that they walk in and they're talking and they seem like they're breathing normally, and within hours that can change and they can be on the ventilator that is actually breathing for them. And so the rapid onset to the severity is something that we in the hospitals have never seen.
Great. Well, Chris, I know you were, Chris and I were having a conversation the other day about the antibody tests, which is really big in New York. I know you were going to ask something about that before.
Yeah, I was. But actually, before we get to that question, something that you said, Dr. Ihanacho, really sparked a thought. So I've been seeing a lot of news, and this is not just for COVID-19, but historically, the testing that is done with the Black community, right? And there is talk in France around going to Africa to test out different possible treatments / vaccination protocols. Just curious your thoughts around kind of the honing in on that in our community with vaccine trials, treatment trials. And do you find that troublesome, or is that just a part of the process?
I do find that troublesome. Going back to informed consent, I think making sure that anyone who is participating in the study or is determining whether they want to participate, that it's clear what's being tested, it's clear what's being administered, it's clear essentially what the study design will be and what the potential complications that might arise, just so that people can make an informed decision about, is this something that I want to participate in? So I think when it becomes troublesome is when you select a particular group and you try to use them as guinea pigs, as opposed to allowing them to have all of the information so that they can make an informed decision about how they want to proceed. And I didn't see that article, or I didn't see that video, so I'm not aware of all of the particular circumstances, but I know that from colonial times to even our more recent past, that there's a long history of experimental abuses. So we know that it does exist and that it is prevalent. But we're hoping that we can move more towards everyone being on an equal playing field.
Yeah, absolutely. And of course, it is important, as you said earlier, to have a diverse sample of folks to test things out, but do so, once again, equitably, and not just honing in on a community that is seen as susceptible.
Usually you want a diverse population. That's just going to make your test results more robust. Mm-hmm. So the more diverse your population, not only in terms of ethnicities, but age groups, that's going to be better. That's Absolutely. Just a stronger data set that you can generate.
Absolutely. I want to turn this question to Dr. Jewett Patrickson and Dr. Richardson. So as Egwu said, we've been having this conversation about the antibody test. Fun fact, I actually got one this morning, just, to see what was going on. I see your face over there. Is there any value in getting this test? It's hot in the streets right now. What is the value there, if any?
Let me say this. In our hospital, we got approved to use the convalescent plasma. And so what that is giving people who have had COVID and developed antibodies, they've recovered from COVID. We use their plasma, and we do give it to very ill patients that are dealing with acute COVID infection. And so it is necessary to know if you do have antibodies that could potentially help another person that's suffering. So that is the main reason why we're doing the testing, so that we can ask other people to use their plasma if you would donate. So I think that is important. But if you want to know if you have an acute infection, we are still doing the nasal swab in the hospital. And that will let us know acutely if you have the infection. The antibody testing is to know if you've been in contact or been exposed or have had the infection, and now your body is recovering and you're making antibodies toward it.
Gotcha.
So
I think some of the information that the antibody, I was going to just say real quick, the antibody test will be important in the future, just to know who's protected, right? So we can know, like you said, with our testing, how to protect people who aren't tested positive with the antibody. So, hey, we need to stay away from them, or you need to be more careful. So I think in the future, we'll see how effective we're able to, or how much we're able to know about the antibody testing as far as being protective.
Gotcha. Yeah. At urgent care, they're offering the antibody test and the swab, so you can kind of have the knowledge to move forward, and they give you a really robust packet with information about how to read the results. So thank you for sharing that. Egwu, I think we want to talk more about kind of the differences, right, between West Coast, East Coast.
Yep. Yeah. So Dr. Richardson, since you're our West Coast representative out there, we are noticing that when this first started, I think the thought was that California would be this huge, disaster area. It's the closest to Asia, right? So since, the blame is getting pushed on China, but the thought was that California would have much worse results than we're seeing. Can you give us some of the reasons why it looks like California is doing well comparatively to where we are in New York?
Yeah, I think as we've seen, it's really originated in Europe. So there weren't too many people coming this way from Europe. I'm sure there were. The other thing was California was one of the first states to implement the Stay-at-Home Act, where we really shut down everything. Everything that was not essential was shut down here. Also compared to the East Coast, New York, New Jersey is very population dense. We're a lot more spread out, especially in LA County, even though there's a lot of people, there's a lot more areas, so we're a lot more spread out. So there's a lot less opportunity to come into contact with other people if you are doing the social distancing and the stay at home. So those are some of the reasons. There's some other theories out there that really haven't been proven, but I think we were just fortunate enough to really shut down early enough and just to be able to have the distancing that we're able to implement here.
Yeah, that's an important perspective about the density piece. We're starting to see places like Houston, which has a similar kind of spread out nature. Atlanta, there for you, Dr. Juliet Patrickson, starting to open up some more. I'm just curious, and we'll get into this as kind of a final thought. There's some talk about kind of returning to normal, things opening up. While others are talking about the idea of the new normal. So just kind of as a final thought, and we'll start with you, Dr. Juliet Patrickson, and then we'll go to Dr. Ihanacho, and then we'll go to Dr. Richardson. Let's go with the latter, the new normal. What does that look like for you? What should we be expecting? And how should we be approaching these new times?
I agree. I think this is going to be our new normal. Like Dr. Hanachu said, it takes years to really develop a vaccine. And so with that being said, opening up things, which is what we're trying to do in Georgia, they have reopened, and now the restaurants are reopened. But people are still in fear, and they should be, because you're still able to catch this virus, and you can be around people who don't look like they have it and still get it. And so I think our new normal is wearing protective equipment when we're out and about. That is everyone wearing a mask. The gatherings are now going to be smaller. You're not going to be able to get together in thousands and thousands of people. I think it changes a lot of churches here in the South. It changes a lot of concerts here. It changes even you going into your doctor's office. Now you'll be seeing your doctor from far away. And so even the students, when they do return, if they can return, are going to be in smaller size classrooms and spaced out. So it changes our lives drastically. And I think it's something that we have to get used to until we can get a vaccine, which may be in the next 2 years.
I agree with everything that Dr. Jewett Patrickson said. And I think we should also think about our own mental health and well-being, and think about your overall health. So continue to foster those relationships with your family, with your friends. And I think now is the time for us to really start to build more strategic partnerships between scientific researchers, other professional organizations, community organizations, faith-based institutions, where we can come together and see, okay, how can we support each other? And what are the steps that we can take as we face this pandemic together? This is, I think, going to be the new normal. And I'm still trying to wrap my brain around the impacts, because it impacts everything. It impacts the entire way that we have lived to this point. So it'll just be interesting to see what comes out of this. I'm hoping that some health policies will change, especially some of the underlying conditions that people, minorities, both brown and Black people, face now, and how that is contributing to our response or the impact to our lives during this pandemic. So I'm hopeful, and it'll just be interesting to see how things play out.
I definitely agree. I think our new normal right now is uncertainty. We're not too sure what to do, how to move. And I think our best defense right now is prevention, making sure that we're being very careful with the choices we make to go out and do certain activities, that we're wearing our masks, wearing our gloves, really trying to protect each other, because we don't know if you go out, you may be the one that's infecting everyone. You may infect your parents, your grandparents, or whoever, and it could be detrimental. So really, prevention is the key right now, just being very careful with how we move about our daily lives, and adjusting. Mental health is a big thing. But yeah, there's uncertainty right now.
Well, thank you. Thanks everybody for tonight. I think we've just about done it for time. Thanks to our all-star panel that's joined us from all corners of the country. And thanks to my co-host, Chris. I'd like to ask everybody, if you enjoyed, please subscribe so you'll get the notice for our next event that will be coming soon. The topic will be definitely social justice in light of everything that's happened in the last week. So thank you all for coming. I hope you enjoyed Compass Talks.
Thank you.